Hi everyone.
Hey,
Welcome to our Winona live Q&A session. My name is Liv and I help out with the design of the website at Winona, and today I'm going to help Dr. Green and be your moderator. So today we have our Chief Medical Officer, Dr. Green, and he's going to be answering any and all of your questions. So go ahead and start putting your questions in the chat. I'm going to have Dr. Green give an intro and then we can go ahead and get into it. So Dr. Green.
so hi, my name's Mike Green. I'm an OBGYN. I'm some of your guys' doctor, depending on what state you're in and whether I'm the one that is taking care of you. So some of you know my name. I have been an OBGYN for 22, it's almost 23 years now. Spent most of that time in Ventura in private practice, and also helping to run a community hospital clinic system, but mostly taking care of patients. And recently, I'm now working as an OB hospitalist, and I'm also working at a rural health clinic associated with my little local hospital. I now live in Lake Arrowhead, California, which is a little resort town. I live almost at 6,000 feet elevation, so we get all the seasons. We ski, we fish. It's a good time up here. So we started Winona really to help women through the menopause transition. And unfortunately, the whole hormone replacement therapy has been sort of turned upside down during my career. And there's a lot of misinformation about there. And people, both doctors and patients, are afraid to prescribe it or afraid to use it because of this misinformation. But when you really look at the data, it's very safe medication and very effective, and can really help, make your life good while you're going through this. And we really want the second half of your life to be the best half of the life. That's sort of the goal here. So that being said, we want to answer your questions. I want to sort of start off. I had an interesting question this morning from a patient, and I thought it'd be good to kind of share some of the discussion went back and forth. She was worried about starting hormone replacement therapy because she saw her doctor and explained that she had all these symptoms of perimenopause. And her doctor said, well, you should have those symptoms for at least a year before we treat you, and sent her out and told her to come back next year for her annual, and then they could discuss it then. And so she asked me, well, why are you willing to start it right away when my doctor says that we should wait a year before starting? And there is absolutely no data that says that you should wait a year. It doesn't make it safer. It doesn't make it more effective. It's just a year of lost opportunity. So, my answer really is a couple of things. First of all, why be miserable for an extra year when we have medicine that can help you? And so the idea is it's going to make you feel better. It doesn't increase your risk. And in fact, in some ways, it decreases your risk the earlier you start it. Because we know that for appropriately screened patients that start hormone replacement therapy before 60 or within 10 years of menopause, that hormone replacement therapy actually decreases the risk of cardiovascular disease. It decreases the risk of certain cancers, decreases the risk of osteoporosis. It has a lot of health benefits. And the earlier you start it, the more of those health benefits you get. In fact, the reason that we don't start women on hormone replacement therapy after 60 is that we know that the cardiovascular problems that develop because the hormones are low sort of build up. And by the time you get to 60, the data says that over 60, if you start hormone replacement therapy, then you actually increase the risk of cardiovascular disease. And the really issue is that there's already sort of this pre-disease built up, and the hormone replacement therapy can uncover that. So if you start before 60, you prevent this buildup of cardiovascular disease, even though it's behind the scenes and you may not feel it. And so starting it earlier helps prevent it earlier. There's really no benefit to putting off hormone replacement therapy as far as safety or health benefits. And there's a lot of benefits to starting it early. Most importantly, you feel better early. So why be miserable for a year just to prove that you have it? It's not like, gee, is this just a little cold or do you have a pneumonia? Maybe we should, give it a day or two and see before we start you on antibiotics. If you've got menopause symptoms, they're not going to get better. They're only going to get worse. And so it's not like a year is going to clear anything up. It's just another year of being uncomfortable and having these symptoms. So there's no reason not to start hormone replacement therapy right away. You don't have to wait until your periods have stopped. You don't have to wait till you're officially in menopause. In fact, it's advantageous really to start it before that, both because you get health benefits from it and because you feel better. I guess that's all I have to say about that, as Forrest Gump would say.
That makes sense. Yeah, we can hop into some of the questions. So Catherine asked, I'm 52 years old, partial hysterectomy 10 years ago, and currently taking lexapro. Is Winona safe to take while taking lexapro?
Yes, absolutely. There really isn't any negative interactions between lexapro or like medicines and hormone replacement therapy. Because you've had a hysterectomy, it makes the hormone replacement therapy a little bit easier because the progesterone becomes optional. So women that have a uterus, the estrogen can overstimulate the inside of the uterus, and that can cause problems. And so we add progesterone to it to keep that from happening. The progesterone actually can have some benefits, but for a lot of women, they can do well with just estrogen if they don't have a uterus. And so it sort of simplifies things, takes one medicine away, and they still get the benefit. So yes, the lexapro is not a problem. The hysterectomy is not a problem. It sort of makes it easier. The 10 years post-hysterectomy isn't a problem either because you still have your ovaries. So again, we really don't like to start hormone replacement therapy for the first time more than 10 years after menopause, but not necessarily 10 years after hysterectomy unless the ovaries were removed as well. So you'd be an excellent candidate. The lexapro is not a problem. Hysterectomy is not a problem. And medications, if you're having symptoms of menopause or perimenopause, should really help.
Awesome. Thank you, Catherine. Sharon asked, I started about a week and a half ago, and I'm suffering from constant headaches. Is this a common symptom?
So yeah, any medicine can cause headaches. That typically happens at the beginning of treatment and usually goes away. For some people, they're sensitive to one or more of the medications. And so there's a couple of things that you can try depending on what you're on. If you're on both the hormones and the DHEA, it's sometimes the DHEA that can cause headaches. And so you might want to try stopping the DHEA for a week or two, see if the headaches go away, let your body get used to the estrogen and progesterone, and then restart the DHEA. If you're just on, say, the cream, you might cut back to 1 pump a day for a week or two, and then up it to 2 pumps a day to get that transition a little bit more gradual for your body. So those are all tricks that can be done just to help that new medicine transition that people go through. For most people, the headaches do go away once the body gets used to this new medication. Every once in a while, you have somebody that gets headaches from these, and we can't sort of figure it out, and it's just the way it is. It's pretty rare, but if that's the case, then this isn't going to end up being the right medicine for you. But for most people, this is a temporary thing that goes away fairly quickly.
Yeah, and a little bit more information that Sharon added on that is that she's on anti-seizure medication.
I'm sorry,
anti-seizure.
So that should not be an issue. Again, as I said, any medicine can cause headaches, and when you start having combinations of medicines, side effects are a little bit more common. But again, it should be a temporary thing. For most people, it is. Depending on how severe the headaches are, you could try muscling through it. You could try decreasing the medicine and gradually increasing our strategies that you could try.
Yeah. And you can log on to the patient dashboard and talk one-on-one with your doctor.
Absolutely. Yeah. Any of these questions. Yeah, absolutely. We'd love to answer questions. So if you have questions, there's a message function in the patient dashboard, and you'll hook up with your doctor, whether that's me or one of the other doctors. And we're happy to explain things and help you, make this a success for you.
Thank you, Sharon. So next is from Carol Ann. Should I let my doctor gynecologist know I am taking HRT?
100%. The more information we have as doctors, the better treatment we can give you for whatever's going on. And so we really need all the information to help you. So if your regular doctor or your gynecologist put you on something new, please let us know because it may affect the medications that we're prescribing. And likewise, the medications that you're getting from Winona, please let your doctor know because it may affect their decision-making process, and also what other medications you're on, and things like that. So yeah, information is power. The best way for us to help you, us being all your various doctors, is to sort of know what everybody else is doing, so we get the whole big picture, and it makes medicine safer and more effective.
Yeah. The next question is from Alice. I've studied HRT in the UK, and they are getting widespread. They talk about some women needing more hormones because they are active. I have serious depression and taking a high dose of Prempro, which has knocked it out. Can I take as much bioidentical as my depression needs?
Yes, I mean, to a point. So Prempro is a combination of Premarin and Provera. Provera is a synthetic progesterone. It's sort of this is sort of an older medication, and before the smart biochemists and pharmaceutical folks figured out how to really synthesize bioidentical hormones in a way that your body could absorb them, we were sort of stuck with these older medications. So Prempro is sort of the classic older medications, what we all used to use 20 years ago. Provera is sort of known for its side effects, in particular weight gain, and it's sort of a classic side effect of Provera, which is the Pro and the Prempro. Medroxyprogesterone acetate is the generic name for that. But the progesterone that we use, the bioidentical progesterone, is called micronized progesterone, and it's really exactly the same as what your body makes, and so it has a lot less side effects than the synthetic hormone. Provera doesn't tend to cause the appetite increase that Provera causes in the weight gain that goes along with Provera. So I think most of the younger doctors, anyway, have moved to the micronized progesterone as sort of the go-to thing rather than the Provera. Some of the old guys my age, unfortunately, sometimes it's hard to teach an old dog new tricks, and so there are people that are still doing things the way that we did them 20 years ago, and aren't sort of keeping up with the latest treatment. The Premarin part of the Prem part of Prempro is Premarin. Premarin is another older medication, and again, before they sort of figured out how to do bioidenticals in a pill form or a cream form, they were stuck with Premarin, which is not a synthetic form. Actually, what Premarin is it comes from horses. So Premarin stands for pregnant mare urine, Premarin, pregnant mare urine. So they take pregnant horses and follow them around with a bucket, I guess, and collect their urine. And then from that urine, they basically pull the estrogens out of that urine. So those are natural estrogens, but they're natural horse estrogens, and they don't necessarily add up, and they aren't the same as natural human estrogens. They work, but they're not sort of exactly, what we make naturally or women make naturally. And so they also have a little bit more side effects and a little bit more risk. So the estradiol in the pill form, or the Bias cream, which is a mixture of estradiol and estriol, those are bioidentical estrogens. And so those estrogens are exactly the same as what you normally produce in your body. And so they match up with the receptors better and don't cause the same kind of side effects that the older Prempro cause. That's a big rabbit trail, and I don't think that was the question you asked. Oh, you asked if you can take enough of it. So So yes, if you have a dose of Prempro that's working, there's no reason to think that we can't get you on a similar dose of bioidentical hormones that will also work to knock out your depression. The reason I said maybe is really one limiting factor in as far as the creams go is you can kind of only shove so much medicine in a cream before it's no longer a cream. But it's really rare to find somebody that needs so much medicine that we can't get a concentrated enough cream to make it work. So almost certainly, yes, we can find a dose. If there's a dose of Prempro that's working for you, we should be able to find a dose of a bioidentical that's working for you as well.
And then a follow-up question from Alice is that she's 60 in 11 days. Are you saying I shouldn't take it?
No. So this is the same lady that was on the Prem Pro, right?
Yeah.
No, the 60 thing is is people that have not been on hormone replacement therapy before. So women that start hormone replacement therapy before 60, they can stay on it as long as they need to be on it, as long as it's helping with their symptoms. It's a new start. Somebody that's never been on hormone replacement therapy and they're over 60, for those people, the data says that it increases their risk of cardiovascular disease. Now, let's say that you had never been on it and you're 60 and 11 days, and it seems sort of ridiculous that if you were 59 and 364 days, I'd prescribe it for you, but 60 and 11 days, I won't. And it is ridiculous, honestly. But you sort of have to draw a line somewhere. And when you start playing this, well, what if they're 11 days over? Well, what if they're a month over? What if they're 6 months over? What if they're a year over? And you start creeping that line, and then you start causing harm. So you kind of have to have a number that you stick with. But in your case, if you've been on hormone replacement therapy already, there's no reason you can't continue on that past 60. And even switching from one type to another is still safe. Again, as I explained earlier, the issue with the 60 thing has to do with the buildup of issue, sort of cardiovascular problems, because you've been unprotected for all this amount of time. And so what they found in the Women's Health Initiative study, they were starting women on hormones like at 79 that had never been on them. And they found that the first 2 years of hormone replacement therapy, they had a big increased risk of cardiovascular problems. And the thinking was that there was these underlying problems because these women had been unprotected for all this time, and these problems had built up. And then they started them on hormones, and that sort of uncovered this problem, and they had a stroke or they had a heart attack or something bad happened to them. And so it was this idea of being unprotected for a long period of time and then suddenly throwing hormones at the situation that caused the problem. For women that have been on hormones since sort of the beginning, so to speak, they haven't had that problem of building up risk. That risk has been modified, have been decreased with the hormone replacement therapy. So it's safe to continue. I hope that makes sense. But that's where this sort of 60 thing comes from. But for somebody that's already been on hormone replacement therapy, they can stay on it really as long as they need it to help solve the problems that it's fixing.
Okay, the next question comes from Catherine. My mother had breast cancer, and so my doctor recommended for me not to take HRT.
So a family history of breast cancer does not preclude you from using HRT. And there's 2 really big studies that really prove this. And they showed that family history of breast cancer is not really a problem. We didn't see increased problems in women on HRT that had this family risk. Now, the caveat to that is that if you have one of these genetic markers that predispose you to breast cancer, for instance, the BRCA gene or like a Lynch 2 syndrome, that really increases your risk, your personal risk of breast cancer, and you personally have one of those genetic markers, then it's probably not a good idea to be on HRT. But simply a family history of breast cancer really does not increase your risk of HRT. Now, I can tell you that, a lot of us doctors are chicken. And the problem is that a certain amount of women are going to develop breast cancer. I think the number is like lifetime risk of 1 out of 8 women. And so people are worried, gee, if I prescribe them hormone replacement therapy and then they go on to develop that breast cancer that they were going to get anyway, they're going to come back and blame me and sue me over it. And they might, honestly. And so the idea is that, gee, if they have a family history, maybe that 1 in 8 is now 1 in 6, and they're more likely to have a problem, and I don't want to be blamed for it. And, I kind of understand that, the medical legal situation in the United States is kind of miserable, and people are really worried about getting sued because it can be a career-ending problem. And, I am too. But my mantra, my whole career has always been, do the right thing. If you get sued for doing the right thing, it's a bummer. I mean, it really sucks. But you can sleep at night knowing that you've done the right thing. And so to me, that's kind of what the way I practice medicine. And the data is very clear that a family history of breast cancer without one of these genetic markers, it's safe to be on HRT. And so, with a conversation and explanation like that and shared decision making, I think it's completely reasonable to start HRT, even in somebody who's not had breast cancer.
That makes sense. The next question is from Carol Ann. My symptoms are almost all energy related. Low energy, brain fog, but not weight gain or hot flashes, luckily. Are those enough symptoms to start HRT?
If the symptoms are enough to write in and ask a question about it, they must be bothering you. And so the answer is yes, they are enough. It's amazing. It surprised me, actually, when I really looked into this, but a minority, less than 50% of patients actually have hot flashes when they start HRT. Hot flashes, night sweats, those are the things that sort of stereotypically we think about when we talk about menopause and perimenopause. But the truth is, a lot of women never really get those or don't get them enough to be a problem. But instead, they maybe get these other symptoms. And so there's no reason to not use hormone replacement therapy just because you don't have the stereotypical symptom when you still have symptoms that can be improved. So, it's sort of funny. When I was in medical school, my sister called me at like 3 a.m. because her husband was short of breath and having a hard time breathing, and she wanted to know what I thought she should do. I said, April, if you're worried enough to call me at 3 a.m, hang up the phone and call 911. And that's sort of kind of how I feel about your question. If you're worried enough to be on this forum and ask this question, this must be enough to be bothering you. And if these symptoms are bothersome and getting in the way of what you want to do and making you not feel your best, then you might as well take the medication that's going to make them better, and you're going to feel better, and it's going to improve your quality of life. So yeah, absolutely. I think those are enough to start HRT if they're, enough that it's getting in the way of what you want to do.
That makes sense. And I'm going to send in the chat. We have an ebook that goes through all the different symptoms. So there's quite a bit of symptoms. So the next one is from Sharon. Answer that. Hilda said, efficacy of cream versus pill for weight gain and energy.
So the creams and the pills basically, I think, work just as well. I have had patients, and I don't know why, but the human body is funny this way, that I put on the cream and it didn't seem to work for them, and I switched to the pills, and all of a sudden it's working great. And I've had the other situation too, where people started on pills, didn't seem to work. We switched over to cream, all of a sudden, hallelujah, it's fixing the problem. And I don't know why that is. The human body is, as much as we know about the human body is unique in everybody. And it's just sometimes one thing works better than the other for some people. But on average, I found that the creams and the pills are equally effective. And so it really comes down to convenience and personal choice and what sounds better to you. There is a theoretical advantage of the creams in that there's something called first pass metabolism. So when you take a pill gets absorbed in your gastrointestinal tract, and that blood from the gastrointestinal tract pretty much goes straight to the liver, and then it moves out to the rest of the body. And that's called first pass metabolism. And so it puts a little bit of a greater strain on the liver when you take medicines by mouth. When you take medicines through the skin as a cream or a patch, they go into the general circulation. They do eventually get to the liver, but they don't all go in at once. And so they don't hit the liver kind of quite as hard. And so theoretically speaking, the creams are a little bit safer and a little bit easier on the liver. But the truth is, it's more of a theoretical difference. And I don't think the differences are that great for the vast majority of patients. If somebody's got high cholesterol or lipid problems, or they have some liver issues, then maybe the creams might be worth that little extra sort of safety valve. But for the vast majority of patients, I don't think it really matters. And so really it comes down to what sounds more convenient to you, what sounds easier for you to remember and for you to use. For some people, they can just throw a pill in their mouth and swallow it. They don't even need water, and pills aren't a big deal. Other people, they have a hard time swallowing pills. For some people, the cream is really easy. It's part of their, like my wife. So she's on the hormone cream, and it's part of her nighttime cream routine. Women are different than men that way, I think, because my wife has all this stuff she does. I just sort of brush my teeth, lay down and fall asleep. But so it's part of her nighttime routine. And so for her, it's really easy to remember and to do because it's sort of part of what she does anyway. And she's not a great pill taker. So I think that's more important, is what's going to be easier for you to do, what's going to be easier to remember. And for the vast majority of people, either one is going to work well. If you need progesterone, the creams come out a little bit cheaper. If you don't need progesterone, if you've had a hysterectomy, the pills come out a little bit cheaper, but they're pretty similar in price. So that's the other sort of thing. As opposed to patches, patches are pretty expensive. They're about twice as much money as either the creams or the pills. So there's another sort of differential there.
Okay, the next question is from Tamara. I gained 20 pounds over the last 2 years. Prior to menopause, I weighed the same amount for my whole adult life. I am active, I eat clean, and my habits have not changed. I was really hoping Winona would help me with weight loss. Unfortunately, that is not the case. I've been taking Winona for 4+ months now. Is there anything else I should be doing differently?
So if you haven't had a thyroid test anytime, in the recent past, you might ask your doctor to check your thyroid. Sometimes you can have, subclinical hypothyroid where, it's not that bad that, you've got full-blown hypothyroidism, but it can be enough to affect your metabolism and your weight. So that's another thing, another place to look. The other thing is really looking what you're doing calorie-wise. Unfortunately, metabolism does slow down as we age for most people. The hormone replacement therapy does help that, but it's not a magic pill either. And it still is going to take a lot of work. So I'm not saying you're not putting in the work, but it may be that, sometimes calories sneak in when, where we don't really recognize it. There's a couple of ways to deal with that. Intermittent fasting I found to be very helpful personally. So that's what I'm doing, and I'm not a skinny guy, but I've been able to keep my weight under control, which has sort of been a lifelong issue for me. And I found intermittent fasting to be really helpful. So if you haven't tried that, it's kind of an easy way to sort of, get things under control. So what I do is I stop eating at 8 at night and I start eating at noon. Some people, that's a little bit too long for them, or some people can go longer. But the idea is that, two things. Number one, there are some metabolic effects, and it can change the way your insulin is regulated and affect your metabolism and your glucose control. The other thing is just practical. There's less hours of the day where you're actually putting food in your mouth. And, I know sometimes it'll be 9 at night and I'm like, ooh, ice cream sandwich sounds good. And I'll look at the clock. I'm like, oh, missed my window. And if I wasn't doing this, I would have eaten that ice cream sandwich. Or in the morning, I do 24-hour shifts at the hospital. And I used to have this habit of grabbing some snacks to eat on the way home. And I realized I was putting 500 calories down just snacking on my drive home. And I found I don't really need to do that. And so that's 500 calories right there a day. 500 calories a day, that's a pound a week. So it doesn't take big changes to make big differences over the long haul. Another option, for some people, that doesn't work well for them. My wife, for instance, if she's not eating all the time, she gets hypoglycemic and just feels like garbage. So that wouldn't be a good strategy for her. So everybody's got to kind of learn their body and find a strategy that works for them. Another thing that you could do is download one of the calorie tracking apps. They're a pain in the neck. Quite honestly, it's not something you want to do for your whole life, but you might really track everything that goes in your mouth on one of these apps for a couple of weeks or a month. And I think you may be surprised where you're finding calories and where you can cut calories in places that you may not have expected. So some of the apps, you can even scan the barcode on the food or and it'll put it in automatically. And you may be surprised that handful of nuts or that energy bar that you're eating actually is full of calories that you didn't realize. So those are other strategies that you can use to try to figure this out. Where can I make adjustments? Because I hear what you're saying. You feel like you're doing everything right, and I'm sure you're really trying and putting effort in. But I bet there's some places that you might not be aware of where you can make a little difference. And a little difference here, a little difference there. It doesn't take that many calories. Can make a big difference on outcome. So those are all strategies that you can employ.
So the next question is from Hilda. I started my treatment 4 weeks ago. Before the treatment, I have not had a period for 3 months. Within 2 weeks of my treatment, my period came. Will I start having regular periods now?
Most likely not. So it's not unusual to get a period sometime in that first month of starting the medication. And honestly, that's pretty normal and nothing to worry about. If it turns out that you're getting regular periods every month, that's probably nothing to worry about either if it's only been 3 months without a period. If, however, you start having irregular spotting or irregular bleeding, that's a whole different story, and that needs to be looked at by your local doctor. Occasionally, there can be things that are underlying, maybe a polyp or some hyperplasia or something like that, that's not manifesting itself because your hormones are low, and then all of a sudden you sort of give that thing hormones and it exposes itself by bleeding. And so that's something that you want to find out about. So 1 period in the first month, nothing to worry about. If it's only been 3 months since your period and now you start having regular periods, that's unusual and I don't expect that to happen. But that would probably not be something to worry about. But you start having irregular spotting or irregular periods, that needs to be looked at. Usually with an ultrasound, sometimes with a biopsy, just to make sure there isn't something going on that sort of got exposed by adding the hormones. And if so, then you want to get that treated. And in some ways, it's like, well, good thing we found out about this now before it became a big problem. So you don't want to ignore abnormal bleeding. But for most people, that's not the case. They get a little bleeding at first, and then that's the end of it, and it goes away.
The next question is, how do you assess initial dosing?
So I have an algorithm I developed. Basically, the first 1,000 patients or so, let me back up. Sorry. So I got to start the story earlier. So what do you do? What does a doctor normally do? How does a doctor pick a dose in the office? Like normally you're in the office, like I'm in the office, you come in, you tell me your symptoms, tell me what's going on. I write a prescription. How do I choose that dose? And it's kind of a gestalt. We sort of listen to the story, we get an idea, we have a dose we think will work. And that's the way most of us prescribe. That's basically all of us prescribe hormone replacement therapy or most medicines. There are certain things that are more sort of textbook, but in general, there isn't a lot of heavy science behind this, behind dosages. And in fact, even things like antibiotics or really anything, the pharmaceutical companies will do studies on a few different doses, see which one works best, and then that's the dose. There's a medication called Cytotec that we use to induce labor. And I remember when that first came out, I was in residency and nobody knew how to dose it. And so we all tried different stuff until eventually studies came out and we had a lot of experience and we realized sort of what the best dosing is. And there's still some controversy over that. So to start the story off, it's like, well, what do you do in the office? You kind of listen to the story, you go with your gut, you write a prescription that usually works for people that have that cluster of symptoms. And so that's sort of the way I started. And then I thought to myself, I want to try and I really wanted to build an algorithm. So honestly, when we first started doing this, I was the only doctor. And the information, I would get the information, and then I would come up with a dose, just like I did in the office. And then I decided, I want to be more scientific about this. And I want to be able to build a system that when we expand and we start hiring other doctors, will be easy for them and we'll give them a dose that sort of is recommended. So I started paying real attention for the first 1,000 patients. I'd come up with a dose and then I'd stop myself and I'd think, what is it about this patient and this cluster of symptoms and this BMI and this history that made me think of this dose? And I started doing that. And then about halfway through, about 500 patients in, I kind of came up with an algorithm. And then I sort of followed that for the next 500 patients. I made some adjustments. And then I kind of came up with this algorithm that spits out a dose now. And so I took away that gut thing, figured out what it was that was really triggering that, and sort of did it a little more scientifically. And then I've been following that now. So now, what do we have? 4,000 or 5,000 patients, I think, have come through Winona, somewhere in that. And I've been watching it carefully and making sure that for the vast majority of patients, that first dose is the right dose. Honestly, I'd rather underdose you so that if I'm going to err, I'd rather err on the side of not enough medicine. My philosophy is that you should be on the lowest amount of medicine, the least amount of medicine needed to take care of your problem. So yeah, I can make you feel better with a ton of medicine, but then there's going to be more side effects and more risk. And so if I'm going to make an error, I'd much rather err on the side of not enough medicine and then increase the medicine, sort of titrate it until we get your symptoms under control. I mean, honestly, I'd rather nail it the first time and get it right. But if I'm going to err, I'd rather err on the side of caution. And so that's kind of what I've been watching for. And I think, I've got it dialed in pretty nicely now. The majority of patients, that first dose is the right dose. Some of the patients, we need to increase the dose a little bit. When we get down to that 2.5, 3 month place where it's like, gee, it should be working by now. It doesn't seem to be working. We need to increase the dose a little bit. Every once in a while, I go too high. People have side effects. We need to back down. But fortunately, that's pretty unusual. And so I feel like I've got it dialed in pretty well, but it's something I keep a close eye on, and I'm ready to adjust the algorithm. So it's kind of a long story, but that's the way it works.
Okay, the next question is from Laura. I visited a NAMS doctor to talk about possibly going on HRT. I started having anxiety attacks in November. I've not had any problems with anxiety at all in my life until then. She told me to take Zoloft, which I'm doing. However, I would rather not be on a mood-altering drug. I also have low energy and am dizzy often. Are these symptoms that can be helped with HRT?
Maybe. So those are symptoms that sometimes are from perimenopause. And if that's what's driving the symptoms, then yes, hormone replacement therapy is going to help. It's possible the symptoms are from something else. But I think there's a reasonable chance that HRT will help and improve that situation. Again, it's a little hard to say just for sure, and it's one of those things that we sort of would have to try and see how you feel on it. But it's certainly possible that this is a cluster of symptoms that for you represents perimenopause symptoms. Everybody's a little bit different, and there's a ton of different symptoms that the perimenopause and the menopause can cause, and it's different in everybody. And that is, it's not sort of your classic cluster of symptoms, but it certainly is a possible cluster that could be from, it could be the way perimenopause is expressing itself in your body. So I think it's worth a try, and it certainly might help.
The next question is, do you work with men? And if no, why not?
Sorry, do I work with male patients? Or do I work with I think you're talking about patients.
I believe male patients. Could you clarify? Or they're typing? Yes, patients.
Okay. So no, we don't work with male patients. So men that are transitioning to females need a totally different cluster of medication. And honestly, it's not an area of expertise that I have, and I wouldn't want to mess it up. It doesn't mean that, that people that were assigned, as males at birth that identify as a female and want to transition don't need the correct medication, because they do, but they need somebody that really knows how to do that. And I just don't have that skill. So one of the, back in residency, one of my mentors said to me, they said, do what you do and do it really well. And don't mess around with things you don't do, because you're going to end up hurting somebody. And I thought that was really good advice. And so I try to do that. I'm an OBGYN, and I specialize in women's health. And I don't have the knowledge base, honestly, to know how to prescribe to males to be effective. And so I do what I do, and I try and do it really well. And that's why we basically just have female patients.
Yeah. My dad's also a doctor, and he was saying, he's like, a really good doctor when they know their limits, and they'll like transfer you to the person who knows what to do.
Yeah, knowing what you don't know is sometimes more important than knowing what you know.
Yeah, exactly. I think so. Carol Ann says, thank you for your answer. I'm excited to start. We're excited to have you. D, new patient here. What is the average time to expect to see improvement in libido? Relationship is suffering. So
libido is a funny symptom. and it's sort of unpredictable. Some of the symptoms, like hot flushes, they tend to improve pretty quickly. Weight gain, that tends to take a little bit longer. Libido is sort of all over the map. And for some women, they see an improvement right away. For some women, it takes longer. And sometimes it can take a few months. The other thing with libido is usually multifactorial. So there's usually more than one thing that needs to be worked on. Certainly the hormone aspect can be a big part of it. But the problem is that even if it starts with the hormone aspect, if it's a while before that gets treated, the problem can sort of grow and develop into other problems. And it can, as you're saying, affect relationships and things like that, which in turn can affect libido. So libido is a difficult one to treat. It's a very common symptom of perimenopause and menopause because as the hormones decrease, libido tends to decrease with that. So replacing those hormones to normal youthful levels really can help libido. Again, for some people, that's all they need. It's a little kickstart, and boom, within like a couple of weeks, people are telling me, wow, my libido's back. I have other people that, they'll message me in a couple months and I'll say, hang in there. And by the third month, they're saying, yeah, I'm really feeling better. And other people, it doesn't seem to help. And I think maybe there's broader issues for those people. So it's a little bit more unpredictable. So you kind of have to see it's sort of individual, whether it's going to help right away or not. But I would, certainly start there, and then also maybe work on some other issues that might be there, to help.
Sharon asks, if you switch from pill to cream, are all 3 hormones in one cream?
No. So estrogen and progesterone are in one cream. The DHEA is not. So the compounding pharmacists we use tell me that the DHEA does not absorb well through the skin. I'm not a compounding pharmacist. And so again, I take the advice of the experts. We have amazing pharmacists that we work with. We're really, really lucky to have these really experienced people. And, I'm not going to put something in the cream just because it looks good on the label if it's not going to work. I'm not a believer in using placebos. And so they tell me that the DHEA cream doesn't absorb well, and so we don't put it in the cream. I know there are people that sell DHEA creams, but if it's not really going to work and it's just going to be placebo, I'm not going to do that. So we do not put the DHEA in the cream. That stays as a capsule, but the estrogen and progesterone can both be compounded into a cream, and they work very well.
Okay. Carrie says, thank you for your answer. The next question is, do you write HGH?
We do not. I don't have a lot of experience with it. I know that there has been some success with it, and I may be wrong. I'll have to look this up. I think it's I think it may be a controlled substance, and if it is, then we absolutely can't write for it. I'm pretty sure that we looked into this about a year ago, and it was something that we couldn't do as a telehealth medication. But unfortunately, we do not write for HGH.
Okay, the next question is from Alice. Does DHEA work as well as testosterone for libido and all brain fog memory issues?
So I think it does. So here's the thing about DHEA versus testosterone. First of all, from a very practical point of view, we can't write for testosterone because it's a controlled substance. So controlled substances, with an exception, require an in-person visit. The exception is that in many states, there's a COVID exception, but that exception is going away. And so sort of we decided when we built this not to sort of build this based on the COVID exceptions, because we don't want to start somebody on a medication and all of a sudden the rules change and now, oh, sorry, can't do that anymore. That's kind of bait and switch and not really fair to people. So we follow the rules that exist outside of the emergency declarations for COVID. And so we can't write testosterone because it's a controlled substance and that requires an in-person visit. However, the DHEA works really well, and the DHEA gets broken down into estrogen and testosterone within 30 minutes of taking it. So this is a common misconception. People think, gosh, I don't need DHEA, I want testosterone. Well, it's not really acting as DHEA, it's just a vehicle to get testosterone into you. The nice thing about DHEA and the doses that we prescribe is that it's not going to get your testosterone levels we're not going to overshoot them. Testosterone is important for women, and it's really an overlooked source of problems for perimenopausal, menopausal women, because testosterone levels at 50 are about half as high as they were when you were 30. And that's a big difference, and it can really affect you. And so you do need, or a lot of women need testosterone replacement. And DHEA is just a really convenient way to do that. Number one, it's not a controlled substance. Number two, in reasonable doses, you're not going to overshoot the testosterone. So it's going to get that testosterone right in that sweet spot of that, mid-range level of where it's supposed to be in a normal, healthy young woman, which is what we're shooting for. You are not going to get bodybuilder levels of testosterone. It can be done with DHEA. Actually, there are people in the bodybuilding community that take massive doses of DHEA, and it does get their testosterone levels way high, but that's not what we're shooting for. So, and unfortunately, because of that, on the internet, there's a lot of these side effects you read about with DHEA, but it really has to do with the fact that people abuse, in my opinion, but they use huge doses of DHEA to really drive their testosterone levels to sort of really, really high, more than normal physiology would be, and that ends up causing side effects. The DHEA that we prescribe, we don't prescribe this kind of doses, and so it will get the testosterone up to a nice level, but it's not going to overshoot it. So it's really a safer way to do it. You tend to get the benefits with the testosterone without having to worry about the side effects. When you're using pure testosterone therapy, either as cream or pellets or injections, you've got to be really careful about overshoot. And so that you have to follow levels all the time. It's a really tricky drug to do right. And so that's really another big advantage of the DHEA. It's easy. It works, it's easy, and it's hard to mess up, as long as you don't go too high on the dosage. DHEA actually is a banned substance for some professional athletes. So if you're a competitive bodybuilder, you want to look into your organization. And the reason is because it works. So, but again, we're not going for bodybuilding doses of DHEA. We're just trying to get you feeling like you did when you were younger.
Okay, we don't have any more questions. So if you have any burning questions, you can drop them in the chat now.
And if you do have questions and you don't get a chance to ask them, please ask me or your doctor in the patient dashboard and the messaging. We're very happy to answer your questions. You don't have to wait until the Q&A, the live Q&A. We're
monthly
available all the time.
Yeah. Okay, we got one though.
Okay.
Hilda said, I have elevated cholesterol levels for the past 2 years. Do you recommend just taking the cream and not the DHEA pills? Possibly just increasing the dosage of the cream and no DHEA supplements. So 3 questions there. The first one being, do you recommend just taking the cream and not the DHEA pills?
No, as I stated earlier, there is this theoretical thing with cream that it bypasses the first pass metabolism and theoretically affects cholesterol less. But it's not that huge of an effect. And so using most of your hormones, which is going to be the estrogen and progesterone in a cream form, and a little bit, which is the DHEA, probably is not going to affect your cholesterol. Furthermore, if you're on a medication that's controlling your cholesterol, it's probably not going to be an issue at all. So I think if the DHEA is helpful, it's safe to use it. If you want to try just the cream first, that's a reasonable way to go as well. That's, get you on the cream, maximize the dose, see how it does for you. If there's still sort of holes in the treatment and there's still some symptoms that aren't being treated, then we can come back and add the DHEA later. So that's another way to go about it. So there's a lot of different strategies, and there's no one right way to do this, and it sort of depends on your individual feeling about what you want to take, what small risks you're willing to take to get the benefit. I guess the risks are pretty small, but again, it's okay to start slow and work your way up if that makes you more comfortable. There's not a problem with that.
Okay. The next question is, how does stress affect the effectiveness of the cream and pill?
Well, stress, stress is hard on everything. And so stress is going to, make it so that nothing works as well. But that's easy to say. It's hard to tell someone stop being so stressed. Then they stress out about being so stressed. The cream, the medications can still work in somebody who's in a stressful situation. And in fact, it may be a blessing because it takes away some of those symptoms, which takes away some of the stress. Stress isn't good for anybody for any reason, but it doesn't preclude the medications from working. But whatever you can do to decrease your stress it's good for you in general. It's good for your health. It's good for your blood pressure. It's good for your mood. It's good for life. A less stressful life is pretty beneficial. And so looking for ways that you can decrease stress points in your life is an important thing to do. And figuring out what's causing me stress. Is it something that I can avoid? And if so, avoid it. If it's something I can't avoid, then how do I, mediate it to try and decrease it? I'll give you an example from my own life. So I live in a small town. I love to fish. And so I kind of lobbied and got myself put on the fishing committee, which kind of sounds like a joke, but to me, it sounds like that's going to be really fun. I get to be involved in what fish we stock in the lake and stuff like this. Well, it turned out that this thing was like ridiculously political for no particular reason. And it was just causing me horrible stress. And so I finally realized, why am I doing this? It's not fun. It's causing me stress. And so I resigned from the fish committee and I felt a lot better after that. So those are the kind of things that, you should evaluate in your life. What's bringing you joy? What's bringing you stress? Some things bring you stress you can't avoid, but some you can.
It's hilarious. I just wouldn't expect that to be a political committee. Kimberly said, I'm on the lowest dose of estrogen cream. If I add the DHEA pills, will that increase the estrogen too much?
Most likely not. The estrogen contribution from the DHEA is pretty small. It's not zero, but it's pretty small. It's really the testosterone we're after in the DHEA. The amount of testosterone a woman needs is a lot less than the amount of estrogen she needs. And so usually the estrogen component from the DHEA doesn't really affect things too much. So if you're already on a small dose of estrogen, adding the DHEA probably won't be an issue.
Okay. Do you recommend having a full blood panel pulled before starting to establish a baseline?
No. So I guess it depends on what you're asking. So there are certain blood tests that we all should get every now and then. Your thyroid should be checked, your cholesterol levels, CBC every now and then. For me, I have to have a PSA check for my prostate. You probably don't have one of those. You don't have to worry about it. So, you need to do all your normal health maintenance. That's important. But it doesn't need to be done before you start treatment. Hormone levels are really inaccurate and pretty much not helpful at all. They vary greatly, not just day to day, but even throughout the day. So it sort of depends on, what day you got it drawn and what time of day and a bunch of other things. And so they don't really tell us much. So I've never found blood tests to be that helpful or really helpful at all in deciding who's a candidate for HRT or how much to use. And really, that's the standard of care. If you look up, there was a New England Journal article about a year and a half, 2 years ago. It basically said, it was like a cry, stop getting a hormone test for starting HRT. You're wasting everybody's time and money. But you still want to do your normal health maintenance. So, if your doctor's ordering labs every year to keep an eye on you, like mine does for me, that's great. You should do that. But it's not something that you need to do before you start the medication.
Okay, the next question is, can progesterone pills be taken every other night at 100 milligrams, or does it need to be taken nightly? I ask this because in the past, my progesterone has gotten too high.
So progesterone can be used every other night, and that is enough to protect the endometrium. It may not be enough to give you the beneficial effects of the progesterone, but it is a safe way to do it. The problem with the every other night strategy, if Progesterone is fairly unforgiving, and if you miss a few doses of progesterone, it's going to make you bleed, which is obnoxious. So if you're on progesterone every day and you miss a dose, it's probably not going to be a problem. If you're on it every other day and you miss a dose, you have a pretty good chance of having bleeding, and then everybody gets scared because, oh my God, where's the bleeding coming from? And it's probably just coming from missing. So if you can be really good about every other day, it's a safe way to do it, and it's certainly reasonable. But just be careful, because if you miss a dose, it's going to be a lot less forgiving than if you're taking it every day.
The next question is from Kim. How long does it take to start losing weight? Belly fat is an issue for me.
So it's a little bit different for everybody, but from my experiences, for most people, it takes a while. Like the 2 to 3 month mark is when people usually start noticing some improvement in the weight. And then it usually just kind of keeps getting better from there. The first month can be frustrating because it's not unusual to have some water retention and bloating. And so the scale goes up and you feel fatter because you're bloated. That tends to go away on its own pretty quickly. The other thing is that if you're in a situation of weight gain, first thing that's got to happen, well, first of all, we're talking about metabolic effects. So it's not like a diet pill where it decreases your appetite right away. These are metabolic effects that take a while for those changes to occur. And then once those changes occur, first, you've got to stop gaining weight. Once you stop gaining weight, then you can start losing weight. So it's like you've got to, tip that scale the other way. So I say this online a lot, but it's sort of like reversing a moving train. First you got to stop the train from moving, then you can start pushing on it to reverse. And so that can take a while, and it's frustrating. But I try to be honest. The last thing I want to be is a snake oil salesman. And there are people that sell stuff, and it's like, oh, you're going to lose all this weight right away, and that's not going to happen. This, for most people, really is beneficial and helps, and particularly with the body weight composition. So moving that fat out of the tummy, out of the central area, and back to that sort of more hourglass shape that you're used to. Also, it's going to help with muscle mass. And so what you might notice is that the pounds don't necessarily go down, but your clothes are fitting better and your shape is more the way that you want it. But those changes take a while. And so you sort of have to be in this for the long run. But for most of the women, it really does work. And they start noticing these changes after a while.
Okay. Sam sent a little fish emoji when you're talking about your fishing. Alice is our last question. Is there any increase in blood pressure with the treatment?
So for certain women, there can be. So women that are susceptible to high blood pressure, the treatment can increase blood pressure. It's something to kind of keep an eye on. Somebody who has high blood pressure and their blood pressure is controlled, usually this is going to be fine. And so people that have uncontrolled high blood pressure, really you need to get that blood pressure under control before you start medicine. For most women, this is not going to affect their blood pressure, but in a small minority of patients, it can. And so it's not an unreasonable thing to keep an eye on. And this is something sort of in my head, I've kind of gone back and forth. Should I ask for blood pressure before we start the medicine? And I just think it's a big hurdle for people, and I don't think it's really necessary. But if there's somebody with a family history of high blood pressure, or it's something that you're worried about, or you're sort of on the borderline, it's probably something to keep an eye on when you first start treatment, and see if you're one of those, that minority of patients that is susceptible and does get the blood pressure, and it does elevate their blood pressure. And if that's the case, then you want to see your doctor, get on blood pressure medicine, and then the hormone replacement therapy can be safe for you. But yes, it is possible, but less likely.
Okay, that's our last question. So thank you everyone for joining. You will get a replay of this. So if you joined late, you'll be able to see the replay of the previous questions that Dr. Green answered. And we have these every month. So if you have more questions, you can talk to your doctor, or you can also join our monthly webinar.
Thanks for spending your time with us. I appreciate it. I hope this was a good use of your hour. That's what we strive for.
Amazing. Getting some thank yous in the chat. Well, thanks everyone, and we will see you next month.
All right. Take care, everybody.
Bye, everyone.